Good afternoon. I'm Professor Jonathan Weber, and I welcome you to this latest CumbriaMed Research Webinar Series. I'm the co-director of the Research Hub at the Piers Cumbria School of Medicine, together with my colleague, Professor Sophie Day. And we really bring together research across the NHS Trust in North Cumbria Integrated Care NHS Trust, NCIC, together with the University of Cumbria and Imperial College London, the partners in the new Piers Cumbria School of Medicine. And the purpose of the webinars is to bring together speakers from Imperial, from the University of Cumbria, and from the NHS in Cumbria to talk about research topics of interest and to look at the activity and cutting edge nationally and in Cumbria. So in this webinar this afternoon, we're going to be looking at the contentious area, emergency care, or unplanned in emergency care, and known to all of us, I suspect, as A&E. So without further ado, I'm going to introduce our first speaker, Professor Julian Redhead. So Professor Redhead is both the incoming chief exec of Imperial College Healthcare NHS Trust in West London, now the highest scoring NHS Trust in the latest NOF score, and many congratulations to the Trust for that. Julian's also the senior lead at NHS England for unplanned and emergency care, so brings a national perspective and as a national leadership in this area. So, Julian, thank you for coming along this afternoon, and I look forward to hearing to your presentation.
Jonathan, thank you very, very much. And obviously that role with the national team is actually ending now as I go into that chief executive role. But I'm really happy to give a sort of the national's perspective as it is at the moment. I'm going to share some slides, if that's okay. And you always hope that actually works. Yep, great. Okay, so I think the first thing to point out is as the new government came in, they got our own Lord Darcy to do a review of the NHS, and he did an independent investigation of the NHS. And I think one of the areas that he did concentrate on was urgent emergency care, pointing out quite long waits for care, but also pointing out research which suggested that there were harm coming to patients, both from mortality and from other aspects, to patients due to those long waits in the ED as well. So I think what we need to do is understand those and what we've been doing to try and put that position correct and where it sort of sits in the whole spectrum of healthcare. So why did he say this? Well, if we look at these graphs, they give part of that story. So the top left-hand one is the 4-hour target. So the constitutional target is that 95% of patients should be seen and treated within 4 hours. And as we can see, back in sort of 2010, before the pandemic, that was being achieved at around in most departments. And nationally, we were achieving the 95%. And after that time, there has been a steady decline in those performance, partly then being taken over with COVID, but then continuing a downward trend, although more recently we've managed to stabilise that. And over the last 3 years, there's been an increasing performance across the country against the 4-hour target. So we're now going to be sitting at around 97.5%. Probably by the end of this year, or somewhere around that figure potentially. There's still lots to go, and we may still get up 78%. And then the category 2 mean, which is the time it takes for an ambulance to arrive for a patient where they have the potential for heart attacks and strokes, those types of things. Although it's a very wide, broad area of why ambulance gets dispatched. And the target for that is 30 minutes, although the previous national target was 18 minutes. And as you can see here, although we've done a lot of work to improve that position and now achieving that 30-minute target, that has been very rocky on the year by year. The black line is this year, and the darker green lines and lighter green lines are the previous year. So you can see various improvements going on in those. The one where we've made less improvement is around the long waits, the 12 hours from arrival in the department. And although there has been some improvement in those, that is what leads to corridor care, and something which both the government and ourselves do not want to see, and also making sure that patients have the right experience. So why are these occurring? Well, I think the first thing we've got to understand is that demand is increasing year on year into the emergency departments. And these graphs going back to the one, you can see the rise, and that rise has continued after this graph in 22-23, and we're still seeing that exponential rise occurring in demand for emergency care. But that demand is also occurring across all pathways. So our colleagues in primary care are also seeing that demand of need for urgent and emergency care. And we shouldn't forget that that is across the whole board. But some of that increase, and the majority of the increase, is actually sitting in urgent care. And here I probably need to do a definition between the difference between urgent care and emergency care. And I think the way I define it, and it's not nationally recognised maybe in this, is that if you've got the need for a time critical intervention or the potential need for a time critical intervention, I would argue that you are in an emergency need. Others would therefore be in urgent care. You might need some sort of treatment that day, but isn't the urgency of a time critical intervention which needs to occur straight away. So we can see that the bigger rise has been occurring in the urgent care, so there are less need for emergency consultant skills than in the type 1. We've also seen a very big change in where referrals and where patients' admissions come from, where it used to be sort of half and half between primary care and patients presenting. It is now almost entirely sway towards patients self-presenting into the emergency department rather than coming through the GP, which I think does reflect how busy GPs are and the well-documented access issues that there have been in the past to GPs, although those are improving. And when we see those increased admissions, and you can see that through the graph there, that does cause problems in terms of occupancy. And we can see here the rise in occupancy, but also the rise in the number of beds available across the NHS as well, trying to keep track with those demands. But the occupancy levels go very, very high. And this graph reflects national occupancy. So this includes sort of both the normal beds you'd see in a hospital, but also intensive care beds, elective beds, and everything. So when we run at around 95, 94%, that is incredibly high. And most of the departments would be running at a much higher percentage. That would mean a lot of departments would be running at over 100% occupancy, and hence we get into corridor care. And then I think we've got to look at the future here, because the population we're serving is going to get older. And we can see this in terms of the projection growths in the elderly population as we go through to 2031. And you can see that very starkly on the graph on the right. And also the complexity of our patients, the number of patients who'll have more than one comorbidity occurring will be increasing as well. So we have to keep preparing ourselves for this future situation that the population will find itself in. And I think we've also got to pay attention to health inequalities. And we can see here that as our deprivation axis goes down, so those who are most deprived are more likely to be using our A&E departments, and therefore those are areas we've really got to rethink about as well. The public themselves are very confident that they can see a doctor, confident in deciding that they need to see a doctor or do self-care, and these are research coming out of NIHR on this. And once they've made a decision that they want to see a doctor, they want to see that doctor straight away. And I think that is an important aspect of emergency care. And that's why emergency care exists, to be able to link that back to what patients really want. Now, one of the benefits that I have in my national job is talking to lots of different patient groups. And I know there'll be some patients on this call as well, so you can add to this wealth of knowledge. But every time I talk to patient groups, what they tell me are four things about emergency care. And the first one is that they want to know they're not dying. Patients don't just go to A&E for no reason. In general, they're concerned about their health, and they're usually very concerned about their health. And so the aspect of being able to make sure that they can see somebody to reassure them that they're not dying and where they're going to go is actually a really important part of emergency care. And that's why we have triage, and we have senior doctors and senior nurses as far in the front of the pathways as possible. And the more that we do that, that reassures the public, but also allows us to start to investigate patients in the right way. The other thing that comes out is that patients recognize they may need extended care outside of ED, and I'll come back to why in a second. But they like SDEC, okay, as a place. They really like going there. They feel that it adds value to them, and it's away from the busyness of the A&E department. So long as it's adding value to them, they absolutely like that model of care and don't mind that they may need to have extended waits in ED to receive the care when they know it's adding benefit to them. The third thing is they really want timely access to information. They want to know how long they're going to wait and what happens. And in an emergency department, that can be really difficult because we are dependent on the next patient coming in and to how their needs for care maybe need to be faster than the care of that patient that's waiting. So it is always variable to say how long a waiting time is. But in other environments, such as urgent care, which I'll come back to, and in terms of SDEC, that information is much more readily available and much more consistent for patients. So they like that. And then the fourth one is that once the decision is made to admit, patients do not like to wait for a bed, and they really want to make sure that they're going straight to a ward if possible. I think the other aspect to this is healthcare is changing, and it's a map just showing some of the changes and revolutions which have occurred in healthcare, and that is happening all the time. So the amount that we can now do in terms of imaging and investigations and indeed treatments for patients in the A&E department and in extended areas is increasing, and that means that we don't need to admit patients. So patients can be cared for back home once we've got to the diagnosis and the correct treatment. So the way that we treat patients is changing, and we need to recognize that as well. So throughout our time, this is a very simplified diagram now of a whole sort of urgent emergency care system. But if we think about different aspects of this, the first one is left shift, which we hear about a lot from the government. And this is really trying to make sure that patients are cared for away from the hospital. Now, for me, if I go back to a definition again, I would say that neighbourhood health is about reducing the time that a population needs to spend inside hospital. So that may be the time it's as an inpatient, the time that it needs to go to hospital, or indeed going to outpatients as well. To me, that's where neighbourhoods and left shift can really make a difference. And within neighbourhoods, that is about proactive care. It's about continuity of care, because we know that if we've got continuity of care, length of stay and need for healthcare resources goes down, and how we make sure we've got urgent responses for patients who need them. But once the patient does arrive in the ED, then there are things that we can do for them there in a different way when we think about all the demographic changes and everything that we've spoken about already. So the first thing is making sure that we can differentiate those patients who need an urgent need as opposed to emergency care. Because at the moment, what we've done is overcrowding our emergency departments, but there's a whole lot of patients who don't necessarily need that time critical intervention together with urgent care. So separating those out is actually really important. And research here would suggest that somewhere between 30 and 70%, because of varying in populations, are more suitable for an urgent care environment than for an emergency care department. And most patients like that environment because it's very difficult to have a conversation with someone who's lying on a bed when they don't need to lie on a bed, and being able to talk to them on their eye line is actually very important in terms of environment as well. So these things all make a difference as we go through that. And then being able to move patients from where they're seen very quickly by very senior doctors into extended care areas if there's more that we can do. So carrying out CTs and indeed MRIs and being able to give treatments to patients, which means they don't need to be admitted into hospital. And that can be extended care areas where they're under the emergency department because of continuity of care, or indeed referred on to acute medicine or to specialities, who again may be able to do more for those patients before being admitted into hospital. And that's really the crux of where we see within the model ED, which is a recent publication across the country. But it also is in that interface between neighbourhoods and emergency departments as well. So colleagues in emergency medicine are also carrying out calls with ambulance services to help the ambulance service decide whether a patient needs to come to the ED or could again be diverted or stay at home or to different environments. And again, research is suggesting that somewhere around 40% of ambulances in some populations are able to be taken away from coming to the A&E, but into a better clinical environment or giving care at the patient's own home. So again, the way that we're changing those are very much there too. And then finally, in the hospital itself, we've got to think about continuity of care and not moving patients between teams. So we put out a document about the first 72 hours of care, because that is a really important area. Most patients only need an admission for 72 hours. There are groups which may need longer, but most patients, we should be trying to get to those diagnoses, get to those treatments in that first 72 hours. And then also being able to get that continuity care through specialists who may know the patient really well, sometimes better than the GP, and making sure we've got continuity of there. And then making sure that variation across our trusts and our social care and our community care and the variation in discharge is a very important aspect here as well. And making sure we're making best use of practice, because the longer patients stay in hospital, the deconditioning occurs, especially in patients who are frail, but also they're more likely to pick up infections, etc., while they're in the hospital as well. And then finally, how we discharge patients back into neighbourhoods, because it's the same teams that are there to care for patients, both avoiding an admission and those who are taking those patients back out to discharge and making sure they don't become readmitted. And there's obviously virtual wards and hospital at home are big innovations in this area, which we can come back to when we talk about innovations. There are three groups of patients who I must mention just because they are really important here. One is mental health, one is children, and one is frailty. And there are different aspects of care for those which we're also looking to improve at all times to make sure that those particular groups are cared for well within our emergency care services. And examples of mental health, where they're talking about, we're looking at co-location of mental health facilities within the ED to support the care of patients who have both mental health and physical health needs. And it would be wrong of me not to then end on this bit, which is around innovations. And there are huge amounts of innovations which can occur in this emergency medicine department. And I know Imperial College are involved in some of this and other areas as well. The first one I point to is big data. And the more that we can use the data that the NHS generates to look at different pathways of care. And obviously for Imperial, in Northwest London, we've got the whole system integrated care database, which we've got information which takes you from where you see your GP into the A&E, into the hospital, back out into community services, and we can track individual patient journeys through all of those different data sources. And that really helps us understand patient movements and patient pathways. Together with that, Imperial College has got a very big aspect in natural language processing and how do we extract information from clinical records for the benefit of patients, but also the benefit of staff, being able to interpret the electronic patient's record, bring that in to a discharge summary, much more easier when we can use natural processes to do that. And then a big thing about ambient voice technology, which we've got to be careful here because of safeguards on GDPR, but where an AI system can actually listen in to a consultation and automatically generate a letter and a summary of that for a patient in the language of their choice. And the AI can also interpret it and suggest different diagnosis to the doctor to make sure they haven't missed drug interactions or other aspects or rare conditions, which may be beneficial as well. The other area where Imperial really leads the way is around wearable and home technology, and especially in cardiac cases and things like this, we're really looking at that. And that's going to become more and more important as patients are cared for more at home than in the hospital with that left shift. So how do we monitor patients correctly with that? And then what we can do also is to identify patients at risk through AI identification. And there are research studies occurring actually in Northeast London at the moment around how you link that to health coaching. And what that's suggesting is if, again, we're proactive in our care, it may reduce the time patients spend in hospital, but also the attendances in ED. And that information is coming all the time to us. Point of care testing will also be an important area. And the more that we can do point of care testing for patients back in their own homes or in local community settings will be important. So patients can therefore get the diagnosis of an infection. Now, this is where this could really help with antimicrobial resistance, another important area for Imperial and for the country. And the development of the Fleming Institute here will be very important as to how we reduce antimicrobial resistance. And the more we can get accurate information about the bacteria that a patient may have, the more we can target the correct antibiotics for that. And we can continue down through all of this for genomics, different blood markers for head injuries, strokes, etc., and then robotics. So there's a whole area of innovations which will help us throughout the whole pathway for emergency care. I'm very happy to answer questions, and obviously we'll go on to the next presentation, Jonathan.
Julian, thank you very much indeed. And what I'm now going to do is go on to the next speaker, and then we'll take questions at the end. Can I just remind the audience, don't hesitate to put your questions into the Q&A at the bottom in order to put your questions. We'll come back to all the questions at the end. So it's a great pleasure to introduce Dr. Claire Gray. Dr. Gray is a consultant in emergency medicine, North Cumbria Integrated Care NHS Trust, and also the collaborative chair for urgent and emergency care at the hospitals. Claire, welcome. Over to you.
Thank you very much. So I'm just going to share my screen as well. Perfect. And thank you very much to Professor Redhead. So I'm going to be picking up on how we try to apply some of those kind of national thoughts and national framework in Cumbria. So just to start a little bit about Cumbria, I'm sure hopefully most people on the at the webinar know a little bit about Cumbria, but we have a large rural landscape, which obviously includes the Lake District and some quite remote communities. We have urban centres, with Carlisle being the biggest, but also including Penrith. And we also have some coastal areas, Whitehaven and Maryport. Cumbria has a population of approximately 5 million people, and an average age of about 45, which is higher than average for both England and Wales, and indicates that Cumbria has an ageing population. Just to pick up on what Professor Redhead said about urgent and emergency care, my definition of emergency care would involve life-threatening conditions, such as cardiac arrest, severe bleeding or unconsciousness, and urgent care, conditions that require prompt attention but are not immediately life-threatening, such as minor injuries, infections, or worsening illness. And understanding the difference between these two things, and also understanding how our patients perceive the difference between these two things helps us plan the way that we care for our patients. So in terms of the demand and activity for urgent and emergency care, in Cumbria, there are certain influences which are not necessarily unique to Cumbria, but provide a kind of interesting mix. So as I mentioned, we have an aging population that comes with quite complex health needs. We have a rural and dispersed communities. We also have seasonal tourism, which increases population pressure at particular points in time. And also with that, we see some patterns in injury. We also have a higher prevalence of chronic conditions. So all of this results in sustained pressure on ambulance response times and also emergency department capacity. In terms of the current urgent and emergency care services that we have in Cumbria, we have 2 acute sites, the Cumberland Infirmary, that has 341 acute adult beds, We see an average of about 220 patients per day through our emergency department. The emergency department is a designated trauma unit, and we have medical and surgical SDEC on site in Carlisle. We have the West Cumberland Infirmary over in Whitehaven, where we have 183 acute beds. We have an average of 120 patients per day through the emergency department, and we have a medical SDEC. And then we have our urgent treatment centres, which are located in Penrith, in Keswick, and we have the new urgent treatment centre, which has opened in Carlisle, but is yet to be fully operational. In terms of the emergency departments, both emergency departments have a 24/7 consultant-led care for critically ill and injured patients. As I alluded to, we have a wide case mix, which is partially driven by the mix between urban and rural populations. We have trauma expertise on both sites, which we use to reduce the need for transfer to our tertiary centres. Our tertiary referral centre for trauma is over in Newcastle. So from Carlisle, that is a land transfer time of approximately 1 hour and 20 minutes. And from Whitehaven, that's a land transfer time of approximately 2 hours and 20 minutes. So you can see that from that there are significant benefits to being able to keep some of our trauma patients in Cumbria. That allows them to be closer to relatives, closer to support, and certainly in terms of discharge makes discharge planning much more straightforward. In terms of the specialties that we have on both sites, so both of the hospitals are classed as acute sites, but the West Cumberland Hospital does not have all the specialties on site. So, for example, our surgical specialties and our orthopaedic specialties are not on site at Whitehaven. That means that if patients present to Whitehaven with surgical or orthopaedic conditions, then we need to consider the transfer of that patient across to our site in Carlisle. So for the emergency department, there is a lot of what we would class as transfer medicine and planning in terms of stabilisation for transfer for our patients. So this diagram is just to show a little bit about how our patients flow into our urgent and emergency care pathways. I will bring you on to a second slide, which explains a little bit about what MATCH is. So essentially, you have patients in the community that can either walk in, they can call an ambulance, and in Cumbria, that ambulance service is NWAS, or they can come through their community services, so such as their own GP, Cumbria Health, which provides the out-of-hours GP service. They can present to our rural UTC, so that's in Penrith and Keswick, or they can call 111. So all of those patients that I've just mentioned, then in an ideal world would come through our MATCH service, and MATCH would signpost those patients or healthcare practitioners who are contacting the service on their behalf to the most appropriate place for those patients. And the options we have in terms of streaming people into our urgent emergency care pathways are: we have our UTCs, we have our medical SDEC, we have our surgical SDEC, we have the emergency department, and we also have our community or our hospital at home services. And you can see from the chart the current percentages of patients that go through those services. And as we alluded to earlier, what we find is that patients often prefer the option of going through medical and surgical SDEC. And one of our areas of growth would be to try and improve or increase our services there so that we can have more patients going through that kind of service. So just a little bit more about Match. There's an NHS England requirement to provide a single point of access for urgent and emergency care services. In Cumbria, we call that Match, which stands for Multi-Agency Telephone Coordination Hub. And that provides our GPs with a single point of access to medical same-day emergency care and for medical admissions to both the Carlisle and the Whitehaven sites. The Match workforce is made up of a triage nurse, an ICC therapist representative, a district nursing representative, and a senior clinical decision maker, and an NWAS paramedic. And with that team, then practitioners, so GPs, but also NWAS paramedics in the community can contact the Match and have a discussion with them about patients whom they may be unsure about what alternatives there are to sending them to hospital, or to arrange for them to be sent to hospital. With the introduction of Match, which was brought in June 2025, we've seen a reduction in ED attendances. We've also seen an increase in flow of patients through SDEC, and we've also been able to keep a good proportion of patients at home with advice or with the ability to put in ICC support at home. So that's where the district nursing and the ICC therapist representation comes into play. In terms of our hospital at home and our community services, we also have the ability to stream people into these services without them having to come to the emergency department. So we have virtual wards for respiratory, cardiology, and frailty, who can look after patients who need observations at home and ongoing monitoring, but don't have any increased care needs. The respiratory virtual ward can also provide oxygen at home within 24 hours. We have day units at Maryport, Wigton, and at Carlisle. They can provide blood transfusions, iron transfusions, IV antibiotics, biological therapies without the need for admission to an acute hospital bed. And we also have our community hospitals. So these pathways are currently under development to take a variety of patients. So, for example, step up from the community patients, frailty patients, and post-fracture rehab patients. So I think it's pretty well understood that urgent and emergency care nationally is under a lot of pressure for the reasons that Professor Redhead has already outlined. I think the key challenges for us specifically in Cumbria are centred around the geographical isolation and the long travel times that we have. We have some difficulty with workforce recruitment and retention, and there are health inequalities that we see across our rural populations. So in terms of future developments and improvements, I've already mentioned that there are certain things that we're doing already. So, for example, Match, which is a fairly innovative approach. We are working on strengthening our community-based care models. So we currently have a frailty SDEC pilot running at West Cumberland Hospital, which enables our frailty team to pull patients out of the emergency department and move them to the community hospital for an assessment. And then from there, they can discharge them with some enhanced community care. We're also expanding our virtual care and digital triage. So that's taking into account the push for the kind of digital solutions. So once our urgent treatment centre at Carlisle is fully operational, we will be using the NHS streaming and redirection tool there, which will enable us to stream some patients away from our front door using a digital tool. The Trust is also working through the rolling out of a new electronic patient record, which will help information flow much more freely between the hospital services and will help increase our efficiency as patients move through the urgent and emergency care pathway. We're working on fully operationalising the Carlisle UTC. So that is around we have a beautiful new building, but we are currently working on the staffing for that. So that is employing some substantive GP colleagues, and also making sure that we have enough nursing, AHP and pharmacy colleagues to work there. There is a phase of the building which is not yet finished, which involves co-locating our X-ray facilities much closer to the UTC and also the emergency department. So that should help improve efficiency in terms of getting people through to X-ray to have their imaging done, so that they can come back with an answer and a diagnosis quicker. And we're also working on expanding the SDEC services at both Carlisle and Whitehaven sites, which involves increasing our staffing model, but also improving our estate. So the medical and surgical SDEC currently at Carlisle currently share a space. There are plans that are currently being drawn up to allow them to move into separate spaces, which will help them improve the flow of patients through those areas, but also make sure that those areas are specifically fit for purpose in terms of what people expect to see from an SDEC model. So hopefully that's just a small insight into how some of the national picture translates through to what we're doing in Cumbria, and just a little bit about some of the improvement and innovation work that we're doing here. Thank you.
Thank you very much. Okay, thank you very much. I'd like to thank both the speakers, Professor Julian Redhead, Dr. Claire Gray, for their presentations today and for all the questions that they'd answered. Can I thank everyone who's attended in the audience today very much for their involvement. Meanwhile, thank you all very much indeed. Look forward to seeing you in a month's time.